Hello! Welcome to another episode of Ask PA Mimi. Get ready, and let's make health make sense. Today, we will be talking about giant cell arteritis. It is also known as temporal arteritis. Giant cell arteritis is a systemic granulomatous vasculitis affecting medium and large arteries, particularly the extracranial branches of the carotid artery, for example, the temporal artery, BIE. It is a medical emergency due to the risk of irreversible visual loss. Treatment should begin immediately if GCA is suspected, especially if visual symptoms are present. Causes could be immune-mediated inflammation of arterial walls and granulomatous inflammation with multinucleated giant cells. GCA is often associated with polymyalgia. Rheumatica exact trigger is unknown. Risk factors include age of 50 years and above, female sex, Northern European ancestry, history of polymyalgia rheumatica, smoking, and cardiovascular risk factors. Signs and symptoms include new-onset temporal headache, scalp tenderness or pain on combing hair, jaw claudication, or pain on chewing, and temporal artery tenderness or thickening. Visual symptoms, which are usually red flags, include transient visual loss, also known as amaurosis fugax, blurred vision, diplopia, and permanent visual loss. Systemic features for GCA include fatigue, fever, weight loss, and night sweats. Associated polymyalgia rheumatica symptoms include proximal muscle pain and stiffness of shoulders and hips, morning stiffness for more than 45 minutes. First-line investigations include ESR and CRP, which are usually markedly raised. Full blood count UNEs and liver function tests baseline before steroids. Second-line investigations include temporal artery ultrasound, halo sign, also known as arterial wall edema. The halo sign is increasingly being used as a fast-track diagnostic tool in the UK. MRI or CT angiography, if large vessel involvement is suspected. Gold standard investigation is temporal artery biopsy. This confirms diagnosis histologically. The biopsy should be performed within 1 to 2 weeks of starting steroids. Steroids must not be delayed for biopsy. Diagnosis is clinical and supported by raised inflammatory markers and imaging or biopsy findings. Immediate management is to start corticosteroids immediately, then urgent same-day referral to rheumatology or ophthalmology if visual symptoms are present. If no visual symptoms are present, give the patient oral prednisolone, 40 to 60 milligrams daily. If visual symptoms or visual loss is present, then administer IV methylprednisone for 3 days, followed by high-dose oral prednisolone. Gradual tapering of steroids, usually guided by symptoms and CRP or ESR. Adjunctive treatment for bone protection include calcium and vitamin D, and bisphosphonate if indicated. Gastroprotection like PP, low dose. Aspirin may be considered. Tocilizumab IL-6 inhibitor is a steroid-sparing medication, usually initiated and supervised by a specialist, and it is recommended by NICE for relapsing GCA and for steroid-dependent disease. Complications for GCA usually include permanent visual loss, stroke, aortic aneurysm or dissection, relapsing disease. The prognosis for GCA is usually excellent if treated early. Visual loss is usually irreversible once established, and long-term follow-up is required due to relapse risk. Thank you for listening, and save this video for revision. What topic would you like to listen to? Let me know in the comments section. Don't forget to subscribe, comment, and like for more videos.